Leon cannot come here, I will perform this presentation. The topic is spontaneous coronary dissection, and have nothing to disclosure. And intrahematoma within the coronary artery, we call it a spontaneous coronary artery dissection, and mainly affecting women. And I caught 4% for all ACS case under diagnosis, and the most because of the coronary artery is not good enough. I'm familiar with the angiographic variant of SCAT, insufficient use of intracoronary imaging, and this is left man looks not so bad, but intracoronary errors show that SCAT. And just also as this different present of the SCAT, and OCT show that all SCAT. And this is the case. 31 years old female patient, chest pain 1 week, recurring 2 hours, and a smoking history, denied any history of coronary artery disease, and delivered a boy 5 months ago. And this ECG, not some typical changes. And angiography shows that mid and distal LAD has very diffuse stenosis. The TIMI flow is still TIMI 3 flow. And right coronary, distal, from distal to mid RCA, also very diseased stenosis. And what's next? We do the hours, both the LAD and the right coronary. And this for the RCA from distal. The distal part looks good. No atherosclerosis spark. And then coming the PDA and the distal RCA. From the distal RCA, I have some hematoma. Not very fresh, I think. Some thrombosis. And the true lumen compressed to the 6 o'clock. Big hematoma. Still hematoma. The true lumen compared very small, and then coming a sand branch. Looks this part, and the true lumen is counted here. Where's the average catheter? Just not in the true lumen. And then later it's coming back. This in the just the distal RCA, very big hematoma, and the average catheter in the fourth lumen. And then coming back to the proximal RCA, it looks good. Yeah, here's the cross-section view, and this is the distal RCA, and then coming the PDA, and the distal RCA hematoma, and here another sand branch, and the average catheter still in the true lumen, and then average catheter outside of the true lumen. True lumen is in the 7 o'clock. And more proximal back to the true lumen and normal. And for the LAD, from the very, very distal, the lumen looks very small. Maybe in the very distal segment, and the loop, the vessel is also hematoma compressed, but the vessel, because the lumen is very small, the average catheter, the imaging cannot show the clear border of the hematoma and the lumen. And then we can see the hematoma here from the 1 o'clock to 6 o'clock. And then from the diagonal coming, and the hematoma stop, and more proximal is normal. So here's the cross-section view from very distal hematoma, and more proximal is good. And so for this patient, the operator treats the RCA, and because it's flow limiting, and put a stent. This is the final result of the RCA. For the LAD, they leave it alone. There's the ECG after the PCI, ST segment depression, and T-wave inversion. And for this case, we believe that SCAD is not rare in ACS, particularly in young female. And SCAD is not a benign disorder all the time. When in doubt or need to treat, use intravascular imaging. Initial conservative strategy, unless flow limited, and the best antiplatelet regimen is still a matter of debate. I believe the RCT is needed. I heard just in CCT, I have a section of SCAD, and there is a international multi-center randomized trial comparing single antiplatelet treatment, and the DAPT is now performed. It planned to include about more than 3,500 patients, and will give me more evidence. Thank you.